Thank you, Dr. Bansal. We're going to move on to our next presentation, and that's Dr. Divya Malhotra, and she's going to talk about ischemic mitral regurgitation evaluation. Dr. Malhotra.
Thank you. Good morning, ladies and gentlemen, and welcome to this lovely place. I want to thank the organizers for giving us this opportunity here. The topic I'm going to be discussing is ischemic mitral regurgitation. Ischemic MR is a complication of the chronic healing phase of myocardial infarction. So technically, it is really not a problem of the mitral valve. It is a problem of the LV. In all these years, we've only focused only on the mitral valve, and hence our treatment for ischemic MR has been a problem. It is fairly common. It occurs in 20 to 25% of patients after an MI, and up to 50% of patients with heart failure have ischemic mitral regurgitation. So, you know, this whole thing, we owe a lot to this landmark paper from Gurgaon et al. In 2001 in Circulation, which told us that any amount of mitral regurgitation is bad. In this trial, they had patients who had MI, and they followed them out for 60 months. And clearly you can see that any patient without MR, the survival was 61%, but with any amount of mitral regurgitation, the survival was down to 38%. Going on further, they looked at the affected regurgitant orifice area, and when the ERO was more than 20, the survival was up to 29%. They looked at regurgitant volume. Any volume that was more than 30, the survival was down to 36%. So as a result, looking at all this literature, we know any MR is bad, but the cutoffs for ischemic MR are different than the MR criteria that we use. So for ischemic MR, an ERO of more than 20 millimeters square or a regurgitant volume of more than 30 ml is considered to be significant mitral regurgitation. Now, the problem also with ischemic MR is it's extremely elusive. It's on auscultation, it can have a very soft murmur. We do echoes or TEs before they go for surgery. We tell the surgeon, oh, it's a lot of mitral regurgitation. The surgeons go in and they call us and they say, wow, what are you high on? There is no mitral regurgitation. That's because MR gets affected by afterload and anesthesia. And there's a lot of literature behind this. Bach et al. Showed this, that pre-op, if you look at the jet diameter, was 1.1, and intra-op was 0.79. The jet area fell from 10 centimeters square to 5.7 centimeters square. Again, telling us that the OR is not the place to stratify mitral regurgitation. Ischemic MR and exercise also have a long history. It commonly worsens with exercise. This is because with exercise there's increased afterload. An increase in the afterload further alters the geometry of the ventricle. It pulls the muscles that are supporting the papillary muscle further down. This way the papillary muscles get more apically displaced, pull more traction on the chordae, and bring the leaflets back further down into the LV. Also, if there is there's a worse prognosis if with exercise your ERO is more than 0.13 centimeters square. So what is the mechanism for this mitral regurgitation that we see with ischemic MR? One is alteration of LV geometry. Second is alteration of the mitral annular mechanisms and dysynchronous LV contraction. Alterations in LV geometry. Long thought of, we always thought the papillary muscle ischemia is the reason for ischemic MR. Well, it is not, because when the papillary muscle, they studied this, is made ischemic, actually it elongates, and that may actually decrease the stretching of the chordae and decrease the amount of MR. Also, they said, oh, a very bad heart, we think, is going to have MR. They induce LV failure with drugs in animal models, but they didn't let the LV expand. So if you don't let the LV expand, and just cause LV failure, there was no MR. So, obviously there's a geometry of change in the ventricle that causes this ischemic mitral regurgitation. What happens is, with ischemia and infarction, the myocardial segments that underlie the papillary muscles bulge either posteriorly and outwards and further down towards the apex. So this whole malalignment now pulls the papillary muscles down. This is going to pull the chordae further in and pull the mitral leaflets that should be opening and nicely closing up at the annulus into the LV. And also, because of this geometric changes, there's a huge change between the tethering forces and the closing forces. So the tethering forces are imparted by the papillary muscles and the chordae, and they pull the leaflets away from the annular plane into the LV. And as the LV remodels, which may be localized remodeling at the site of a posterior wall infarction or a big anterior wall MI with a more diffuse remodeling, this will then bring the leaflets into the LV. Also, because of the infarction, the ventricle becomes weak and it can't contract with all that force and oomph. As a result, the closing force, which is generated by the contraction of the LV, reduces, and this closing force pushes the leaflets up towards the annulus. So this imbalance is the reason why you get mitral regurgitation. So this is the tethering force which is being pulling these leaflets down. When there's an infarct, these muscles have got displaced down, outwards and posteriorly. There's increased tethering. At the same time, because the ventricle is weaker, the closing forces are the forces that are pushing this leaflet up. This will further make the leaflets come into the LV and increase the mitral regurgitation. The mitral annulus also is not a very quiet structure. It has muscles around it. It is actually, as we all know, saddle-shaped. The anterior and the posterior horns, sides are the higher ends, and the medial and lateral are the valleys. So the motion of the mitral leaflet is like this. The posterior part of the annulus, the muscle around it, actually undergoes sphincteric contraction, and the anterior part of the annulus undergoes dorsiflexion. So this mechanism together is responsible for decreasing the size of the mitral annulus, getting the leaflets together. And this gets altered with ischemic mitral regurgitation. There are many studies that have looked at the mitral annulus, and you can see this. This is an en-face view, looking straight on from the top. And as you can see, with an infarction, the mitral annulus becomes larger. And this is a side profile and has also becomes flatter. So the whole mitral annulus has now become spread out. It's larger and flatter. As a result, the leaflets which were meeting like this no longer can meet well. They're just pulled further away, adding to mitral regurgitation. Dyssynchrony is another reason that we see mitral regurgitation. We commonly see this in patients who have wide QRS. This is because when there is dyssynchrony, the contraction of the papillary muscles is uncoordinated, and also because when one wall is coming in, the other is not ready to come in. There's a blunted rate of pressure generation that's reduced. The dP/dt is low, the closing forces are low, and mitral regurgitation can happen. The echo parameters of tethering that we see are tenting height, tenting area, and tenting volume. Tenting height is the vertical distance between the mitral annulus and the leaflet coaptation point. Tenting area is the region that is bound by the mitral annulus and mitral leaflets, and tenting volume is measured by 3D echo. This is a clip which is clearly showing that the leaflets are pulled right into the LV, and as you can see there's a huge lot of tenting area here. I'll show you stills. This is a lot of mitral regurgitation. And this area that is enclosed between where the annulus should be, this is where the leaflets should be meeting, but now because of all the remodeling, the ventricle, the LV, the leaflets are moving further into it. So this area here is a tenting area, and then this is the tenting height. Another still just showing the same tenting area, tenting height. Also, we can measure tethering angles. That can be very helpful in our evaluation of mitral regurgitation. This is the posterior leaflet angle. This is the anterior leaflet angle. The wider the angles, the posterior and the anterior leaflet, the greater is the tethering. Again, most stills just showing those angles. We can also measure either on transthoracic TE or on 3D the annular diameter, which is also a very important marker for mitral regurgitation and follow-up of these patients. There are different kinds of tethering that we see with mitral regurgitation. You can have a asymmetric or a symmetric tethering. Symmetric tethering is when the leaflets are both equally pulled into the ventricles, so the side point of coaptation is still central, while asymmetric is the posterior leaflet is tethered in more. As a result, when the anterior leaflet is closing, it closes against the atrial surface of the posterior leaflets. The point of coaptation is eccentric and the MR is going to be eccentric. This is still just showing symmetrical tenting where the central mitral regurgitation, and asymmetric tenting when there's this eccentric mitral regurgitation. The videos. I don't think those videos ran. This was a great review from Jeffrey Selbinger where he looked at certain criteria. This is echo predictors for persistent or recurrent mitral regurgitation. And if the tenting height is more than 1 and the tenting area is 2.5, this is a very high specific value but not sensitive. However, if your leaflet angles, the posterior leaflet angles more than 45 and the distal leaflet angle anterior more than 25, this is both very highly sensitive and specific for recurrent mitral regurgitation. This was a great paper by the group from the Valiant study where it looked at predictors of MR after high-risk MI on transthoracic echo. They had 610 patients. And they evaluated for mitral regurgitation at baseline, at 1 month and 20 months. They measured tenting area, coaptation depth, annular dilatation, LA size, anterior leaflet concavity, mitral annular diameter, and annular papillary distance. This is how they measured. This is your tenting area. The concavity was just measured on the parasternal long axis view. Normally it should be convex, but if it's concave, obviously there's tethering, that is the reason. And the distance from the posterior papillary muscle to the anterior, to the intervalvular fibrosa was measured as that distance. And they found that tenting area was the only independent predictor of progression of mitral regurgitation after MR. If your tenting area is more than 4 centimeters square, your MR is going to be significant. There have been other studies with 3D TEs where they've looked at this. Again, if the annular diameter is dilated, if the tenting area is more, and the tethering distance is more, all of these are predictors for recurrent mitral regurgitation. In terms of treatment of this, we for the longest time just put rings in, tried to correct it, but that is not the way to go. We now will look at treating the other problems which we've seen, to cut the chordae, to do infarct plication, to prevent this further remodeling of the LV, and also the percutaneous mitral valve, the Everest trial where they put this E-valve to get the leaflets in together. So hopefully this was a brief overview of figuring out what mitral regurgitation after ischemia entails. Thank you.